And now we move on to the next session.
Yes.
Yep.
It's going to be moderated by the CEO of IAPO, Kun Kawaldip, Sehmi. Our speakers are Kun Nidhi Swarup, founder, president, Crohn and Colitis Society of Singapore, and Kun Ekawat Suwantaroj, vice president, Thai Hemophilia Patient Club.
Yes, we have a third, well, on the program we have a third speaker for this session, Associate Professor Dr. Aqsa Shaikh from the Department of Community Medicine, Hamdard Institute of Medical Sciences and Research, Jamia, Hamdard, Delhi, India. He's unable to be here in person, but has kindly sent us a pre-recorded presentation.
As always, you can find speakers' full biographies on the 4th Asia Pacific Patient Congress page on IAPO's website.
And while you're there, please, we invite you to submit questions to our speakers, whether you're attending in person or online. And if you're joining us online, of course, you can send your questions via the Q&A tab by the virtual stage. And now, our moderator, Kun Kawaldip Sehmi, CEO of IAPO. So I hand over the floor to you, sir.
Okay. Thank you very much, Masters of Samis. This session is very important to us because we have been working on the Global Patient Safety Action Plan for almost 5 years, trying to look at what needs to be done. It's complete, and now comes the translation of this plan into national action plan. It needs national translation, and that's where you come in. We must translate this into national action. We must put it in national planning structures, and we make sure that all the things that we need are nationally. We're starting off with two very interesting aspects, and then we're coming to it slowly. The first is we'd like to introduce Nidhi. Nidhi comes from Singapore, and Nidhi has been setting up a national patients organization. And we were discussing this issue about having similar structures take over patient safety amongst themselves, having national organizations take over the patient safety agenda and running it. Welcome, Nidhi. Yes, thank you. The second speaker who couldn't join us, and this is it's almost butts into an earlier discussion we had about compassion, is Professor Dr. Aqsa Shaikh. If you look at her LinkedIn account, you find that Dr. Aqsa Shaikh just got her identity documents yesterday. This document is in her choice of identity. And you can imagine where I'm going with this. We have got individuals among our society who are not being afforded the identity they have chosen to be in. So Dr. Aqsa could not travel on the right passport in the right identity because of this. So I'm very pleased that she is nonetheless elected to give us a valuable time. Look at what she's doing for LGBTQ communities. She's been leading on patient safety on that. She's been here in Bangkok a number of times. She knows many of the things here, and also looking at patient safety in a very hostile, sometimes, environment. As you know, all LGBTQ, but we must bring them in. Dr. Aqsa Shaikh will speak on later. And then lastly but not least, I think we need to get the patient's perspective, and Ek has been with us for quite a number of times, has been helping us. He's just come back from Canada, and there's no jet lag. I don't know what he eats, but there's something secret about that. And Ek was telling me how surprised it was that in Canada there were no masks. And I said, you know, they can afford it. Those guys have got 200 beds per 20 patients kind of thing. The health system is too wide. They've got more doctors that they can. In fact, they've taken all of our doctors, you know, from other countries. More doctors that you need, and they can afford it. We can't. Our health system. So EC is very good from point of view of hemophilia. They know about the cases of blood transfusion and patient safety and so forth. EC, welcome on board. I will now ask Nidhi to open the dialogue, and then we can go to Dr. Aqsa Shaikh, and then last EC will choose. Nidhi.
Thanks, Kawaldip. Your intro is pretty elaborate. Thanks for setting the stage. Yeah. My basic introduction is I'm a Crohn's disease patient, and I have a heart for others. So within 1 year of my diagnosis, I set up the Crohn's and Colitis Society of Singapore, and that was 10 years ago. I'm happy to share that after taking medicines for 8 years, I used to take 10 tablets every day. And that's a mild case of Crohn's disease. For the last more than 3 years, I've been off all medication, officially. Yeah, the doctors have approved that. Unofficially, many people do that, but mine is official because I've gone into deep remission with mucosal healing. So naturally, I'm enthusiastic about doing something more that maybe I can pull off this national alliance in Singapore. So today I'll be talking about translating the WHO Global Patient Safety Action Plan. And it focuses on patient and family engagement section into national patient safety action networks and alliances in the Asia Pacific. I think I'm talking to the converted. Yeah, those who are part of this Congress are very well versed with what is global patient safety. But just for the benefit of those who are new kids on the block, it's a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies, and environments in healthcare that consistently and sustainably lower risks, reduce the occurrence of avoidable harm, and make errors less likely, and reduce the impact of harm when it does occur. Now, what exactly is the global burden of unsafe care? I didn't know how big this problem was until I actually went and looked up the document by WHO. So if you look at the second part of my slide, we look at the low and middle income countries where 134 million adverse events occur in hospitals. 1 in 4 patients is harmed. Up to 80% of harm is actually preventable. And approximately 2.6 million deaths occur every year. These kind of statistics are really alarming. And then when you look at the higher income countries, 1 in 10 patients in hospitals is harmed. Up to 50% of harm is preventable. So that's where the Safety Action Plan comes in, which is a 10-year action plan. And there are 7 guiding principles. I don't think I'll go into all details, but basically what we are talking about is engage patients and their families as partners in self-care. And the partners naturally have to be with the government, the healthcare facilities and services, other stakeholders in healthcare, and the WHO Secretariat. I've given the links to the website where you can actually download the entire report and the action plan. Okay, now I talk about Singapore. If you do a quick reality check, the keywords used by most stakeholders in Singapore is patient-centered care, patient-centric care, healthcare enhancement projects, improving patient experience. Yeah? All fancy terms, but where is the patient? We look at the patient's mindset. As patients, we look up to doctors as experts. The patient is a recipient. This is a very old definition of patients from the 1300s, I think. If you go and take a look, that was how a patient was defined. But these days, the definition of a patient is shifting. A lot has to do with the internet and technology. We have access to some information. Yes, Dr. Google sometimes gives us scary information. Might not be relevant to my case, but we do have some access, yeah? And maybe we need to manage that part. Yeah? When you look at patient organizations, what are they doing? Most of our patient organizations are caught up with support services for patients and for fundraising. We need funds to do what we want to do. And we are all operating at different levels of maturity. So what happens at the end of the day is there's very minimal patient engagement. The engagement is at the patient organization level, nothing beyond that. Whereas at this Congress, we are talking about how patients can be engaged beyond a patient organization. Okay? So then the next challenge I throw at most of my audience is try naming a few patient organizations in Singapore. And mostly people can name 5, maybe 10, at most 20. But there are 100 patient organizations in the tiny Singapore. Yeah, it's a dot on the map. And that's the fact of the registered organizations under the Ministry of Health. There are an unknown number of online support groups and patient support groups, even in person. And if we look at what are they doing, they are looking at disease-specific areas, right? Like I would be looking at people diagnosed with Crohn's disease or ulcerative colitis. Someone from the Heart Foundation would look at people dealing with heart conditions. But we all know that the impact is physical, emotional, financial, as well as social. Patients and their family members, the carers, everyone is affected. It's not just the one person who is sick. The whole bunch of people around them need help. Now, when we look at the patient organizations, again, they can be of different sizes. Small, medium, and large, based on the incident rate of the illness or the prevalence rate. Yeah, if we look at it together, that's how the membership size varies. Moreover, if you look at the maturity, I'm trying to maybe categorize them in 3 ways. That one is newly established and trying to find their footing, have even existential issues that can we survive, can we make it? So that's the below 15 years of age. Once they're established, then they would be like a teenager maybe, 16 to 30 years of age. And then beyond 30 or 31, they are quite well established. But what patients don't realize is the 6 potential roles we could play. And this is where, if I can indulge you, can you pull out your handphone and take a picture of this slide? I'll give you a few seconds. Take it because you might not remember the 6 roles. Thank you. And if I go through one by one, we can play the role of a research participant. I think thanks to COVID, many people realize there's a lot of clinical research that goes on in the background, yeah? So we can contribute our DNA, blood cells, other cells from the gut or wherever else for clinical trials. We can be an insight provider where we talk about the general or disease-specific area, about a patient population, the whole group of people dealing with a specific illness, yeah? We can play an advisory role when it comes to clinical research program committees, HTA, disease-specific workshops. Engage patients, please. We can be a reviewer when it comes to various patient-related results, you know. There could be certain trials and other things happening, or they could be articles published, or they could be videos that are being developed. Do it in collaboration with patients and carers. The quality as well as the content will be quite different. We can be co-designers in translating research results. When the results are published, the language I think I can read the first paragraph. After that, I don't think I might get it. And this I'm saying despite me having 2 master's degrees. We don't get it. So speak the language that patients understand. Yeah? Then there is also clinical material that can be converted into patient-friendly information. And the topmost could be a patient that can be a driving force who could collaborate as a partner in projects with patient organizations or with industry. And then they can influence policy making and in implementation. Okay? So overall, what we are talking about is a holistic approach is needed for a whole shift. Especially in Asia, we are far behind the rest of the world. We are not engaging patients enough. And that is where I think the main thing that's needed is a mindset shift. And that shift will take time. We should not rush it because it has to do with the culture. Yeah? It takes time. What we need to do is create awareness. Patients need to know how they can contribute to healthcare. Patient organizations need to be equipped with the tools to identify patient advocates. Then we need to build the confidence of patients that yes, you can speak up. It's safe for you to speak. It's okay, you will not be penalized. That's the Asian mindset, that what if I don't know, maybe the doctor will not see me the next time if I'm too vocal. Something like that. Okay? So collaborate with training providers. Facilitate potential partnerships. So various stakeholders need to come together to make this whole journey happen. So what I'm talking about is a mindset shift for patient organizations, for patients, as well as other healthcare stakeholders. Now, there are basically 3 principles that are needed for better patient engagement. 1, the patient needs to know where to find the community that is caring for their illness. Finding that is an issue. Thanks to Dr. Google, we can find most things these days. But still, it can be daunting for someone who doesn't have access. Then comes education, finding the tools that patients are comfortable with. Somebody who might want to read how to be engaged. Another person wants videos. Another person might say, do an in-person training. That's all I want. So there are different ways and different tools that are needed to educate patients to be engaged. And then comes the part where the patient should be able to find an organization where they can contribute. Be it a hospital, be it a research entity, we need to know where we can help. And this is where I propose the concept of the National Alliance of Patient Organizations in Singapore. And if you look at all the gray boxes, these have been around in my slide for a couple of months, and WHO came in recently, so that's the blue box, okay? So if I go one by one, there's the Ministry of Health, Agency for Care Effectiveness, the Health Sciences Authority, the Health Promotion Board. They can come in and help us understand what on earth is HTA. As patients, we don't understand, okay? Even board members of patient organizations are volunteers. We do not know this. So we need to understand, okay? And fortunately, in Singapore, ACE has agreed to be the training provider for us. Then comes the Center of Regulatory Excellence. They have created a regional platform at the Asia-Pacific level, bringing all stakeholders together. And that is called CAPE. And that is where I first mentioned we do not have such a network within Singapore. We need that. And that's how, okay, I took it upon myself to maybe create it. Then comes the next part, which is the research organizations. There are 4 leading universities, 4, maybe 5, I think. And they are looking for patients to undertake more research. But they wouldn't know that there are 100 patient organizations out there. So maybe through this alliance, we can kind of do a matchmaking, which patient organizations are looking for certain research, and the researchers are looking for, let's say, a whole lot of autoimmune disease patient organizations. So we can bring them together. And again, training is needed even when it comes to qualitative research versus quantitative research. Patients and patient organizations do not know this. we need to be trained, okay? Then comes the next group, a solid funding group. These are the philanthropists, the foundations, individual and corporate donors. They are all looking for meaningful causes to support. And all patient organizations or the alliance is looking for funding. So again, it's a two-way process. So all through my slide, you will see arrows going back and forth. So it's a two-way process. Co-creation is the way forward. Then comes the next box on the bottom right. It's the healthcare providers. We have 4 different segments, if we can talk about. One is the Sing Health group. There are about 9 hospitals and a whole lot of polyclinics under them. There's National Healthcare Group, National University Health System, and the private hospitals. And all of them can actually provide training for patients as to how we can contribute, enhance their care services. I will come to more details later where I will use the Sing Health group example. Yeah. Then comes the next box, which is the industry partners. Yeah. The pharma, genome testing, device manufacturers, the diagnostics, tech, they all can train us as to what are clinical trials. What are we supposed to do in a clinical trial? How do I qualify? Or what are the exclusion factors? What is informed consent form? We don't understand all these things, yeah? Because recently we were healthy people. We didn't care about clinical trials until we got sick and until we reached a point that some medicines don't work. And then we are left with nothing but to go for a new trial, right? So there's a lot of training that is needed at different levels. And of course, the most important is the patient organizations that I've talked about. There are 100 of us and online support groups. And what do we need? We need access to new medicines and devices. And of course, ultimately, we need a cure, if possible, okay? And then comes the blue box, which I mentioned to Kawaldip, that, oh yeah, that's an important thing that I should include, that there is the Global Patient Safety Action Plan, and through this alliance, maybe we can trickle down the implementation and help the process. I have yet to figure out how I will do that, but that's the plan. Now, if we look at where is Singapore placed and where are all of us, we are in the Western Pacific region of WHO. Again, until maybe a year ago, I did not realize WHO actually divided the whole world into 6 regions. That's how ignorant we are. At least I am, okay? And we are dealing with infectious diseases as well as non-communicable diseases. And in this region, there are 5 national alliances. And Singapore, hopefully, will be the 6th one. Now I use a Singapore case study when I talk about national policies and systems in place to eliminate avoidable harm in healthcare. So we do have a Healthcare Services Act. Okay, yes. And we have the Private Hospitals and Medical Clinical Act. We have the National Serious Reportable Events System in place. And there's also a high reliability system that protects patients daily from harm, which includes leadership at the top level. There's a safety culture that is being built within Sing Health, and there's a continuous improvement process built into the systems. So overall, a new national governance structure for safety and quality establishment to achieve system-level improvement is happening under Sing Health. And what they're also doing is there are 5 categories with 13 indicators to be monitored. So that's how it's been broken down to the implementation level. There is an Institute for Patient Safety and Quality, which was only built in 2017 to integrate cluster-wide efforts in patient safety, quality improvement in clinical services, research, and education. And what they do is they develop both healthcare professionals as well as patients to become advocates for and be leaders in patient safety and quality. So there's synergy, there's partnership and solidarity happening in at least one healthcare group that I'm very familiar with. I'm part of the Sing Health Patient Advocacy Network, where 50 patients and carers are part of this network. And you can easily imagine there are thousands and thousands of patients, but there are only 50 people who are advocates so far. We are growing. But we have undertaken 100 service improvement projects with Sing Health. So that's the power of it. And I talk about the time to act is now. More needs to be done. And this is my last slide, I think. I also want to bring up the point that Singapore could host the Patient Academy for this region. And we could partner with the Rotary clubs. I'm a member of a Rotary club for the last 20 years. And I know that in ASEAN, we have recently signed an agreement that the 10 countries come together. There are 1,600 Rotary clubs, and we will support service projects. So health and education are one of our focus areas. So if you need any help, reach out to a Rotary club in your neighborhood, and maybe those clubs can sponsor patients to come to the academy to be trained. So I think I come to the last slide, and that's it. Thank you very much for your attention.
Thank you.
Open to questions.
Nidhi. Thank you very much, Nidhi. I think that was very good oversight. That time for planning globally has been done, but now we must act locally. That's the main lesson here. We must act locally. We don't miss this opportunity. One of the targets Nidhi was mentioning within those targets is to have at least one patient in every decision-making body in your health system. This is what we were talking to the Thai minister yesterday, because I said, you know, you will have to report to the WHO's Director General, what have you done with the Global Patient Safety Action Plan at the World Health Assembly? And the one question you can always get away with is find people here today, invite them to the ministry, and then ensure that you place them at each health system decision-making body you have. It can be done very easily. And the target is 60%. So 60% of your infrastructure decision-making bodies must have one patient included within it. So please work to that. Let's get you guys up there in each of the structures. Now for the next speaker who is joining remotely and sent also her presentation. Whilst we were discussing, I think we were talking to Canon as well, others. The tradition in India on the sides from Bengal, when they have the Durga Puja or the celebration to mark Kali in that region, the tradition is that when you're making that model of the goddess Kali, you must go to every household and get some soil from it. What that means is you must go to the priest, to the cleaners, sweepers, every society member, to the sex workers' houses, to every household that is there. You must include that soil into that thing to show that you're a cohesive society. One of the things that's been missing in the LGBT community action plan, in the World Global Patient Safety Action Plan, has been the LGBTQ community and their perspective. So I will now ask you to play the presentation by Shaikh. Please listen very strongly to this, and
Hello.
It's a personal experience, but also
Aqsa
depth.
Shaikh. I'm Associate Professor of Community Medicine at Hamdard Institute of Medical Sciences and Research, New Delhi, India. And today I'll be speaking about patient safety of LGBTQIA+ patients. I'm extremely thankful to the organizers for giving me this opportunity to speak on this vital topic that is often not covered when speaking on patient safety. And it's really a disappointment that I could not attend this Congress in person. But I hope this small video and conversation can take the dialogue further on this very vital topic. When we speak about LGBTQIA plus patients, unfortunately, it's mired in a lot of misconceptions, myths, and controversies. As it's said that what we don't understand, we fear, and what we fear, then we start judging as evil. And what we judge as evil, we try and attempt to control, and what we cannot control, we attack. And often ignorance and lack of understanding or myths and misconceptions lead to transphobia and homophobia in the society. And since the healthcare providers come from the same society, and since the healthcare system is a part of the social system, unfortunately, this transphobia and homophobia can percolate into our healthcare systems, into the attitudes of the healthcare workers, leading to increased dangers and harms for the patients. Before we proceed further, a quick glance into two important terms. That's what we mean by trans people and intersex people. Now, while intersex conditions refers to the conditions where people are born with a reproductive or sexual anatomy that does not fit the typical definition of male or female, trans people are those whose affirmed gender identity is different from the sex that was assigned to them at birth. We all know about lesbian, gay, and bisexual people, and that's to do with the sexual orientation part. I'll be speaking more about the Indian context where I work, and just to give a glimpse, in India, homosexuality was criminalized like many Commonwealth countries under IPC section 377. Only two genders were recognized till recently. Sojisk was pathologized. It was looked at from the lens of disorder and mental disease. Disorders of sexual development was the term used for intersex conditions, and they were treated because they were considered a disorder. And convergent therapy for LGB and T population was routinely done. But there have been some landmark events in the last decade. In the year 2014, the Indian Supreme Court recognized the third gender. In 2018, the Indian Psychiatric Society released a position statement saying that homosexuality is not a disease and convergent therapy should not be practiced. In the same year, Section 377 that criminalized homosexuality was read down so that it's no longer a crime between consenting adults. In the year 2019, Transgender Persons Protection of Rights Act was notified in India, and in 2020 the rules for the same were notified. In 2021, the National Medical Commission of India put a ban on convergent therapy, calling it a professional misconduct. In 2022, the government launched health insurance providing transgender people cover for up to 5 lakh Indian rupees for doing gender affirming care. And very recently, the medical curriculum was revised in the subjects of forensic medicine and psychiatry to add LGBT competencies. Speaking about some of the challenges and suggested solutions to make patient interactions harmless and safe. When speaking about gender affirming care is routinely done in India and is sought after by trans people. Currently in India, we do not have any national guidelines or standards of care for providing gender affirming care, and most of the people refer to World Professional Association for Trans Health Standards of Care, which unfortunately are not suitable for Indian standards. Also, we need to understand that most of this care is provided by the unregulated private market. Principles of shared decision making are not followed, and there is a huge power dynamics between the providers and the patients. And now with the provision of insurance where the services is brought from the private sector, it is also a difficult thing to regulate in terms of quality. Speaking on intersex conditions, as I was mentioning, it was called disorders of sexual development, and there is no national law even currently that bans unnecessary surgeries on intersex children. However, 2 states of India have put a state-level ban on unnecessary sex-normalizing surgeries in intersex children and adolescents till they are legally able to understand and consent for the procedure. Again, it's very important to involve the parents in the decision-making process so that they understand what is life-threatening and medically necessary and what is medically unnecessary for their children. When it comes to blood donation, the National AIDS Control Program identified higher risk groups from men having sex with men, trans and hijra community, female sex workers, and injecting drug users. Unfortunately, along with that also came a blanket ban on blood donation by these higher risk groups. And that brings into question of ethical debate on risk profiling versus human rights of the marginalized groups. And this was especially seen during the pandemic when a lot of people from the trans community could not get blood from their kins, from their gharana systems who also identify as trans. This is something that needs a serious action, the exclusion of trans and other queer folks from research, especially from clinical trials conducted on new drugs and vaccines, because they are classified as a protected group and often not included, though the products are later on used on them. We also do not have data on gender, identity and sexuality of the research participants who routinely participate in various research, and therefore that does not allow us to get stratified information on how gender and sex plays a role on the results of these drugs and vaccines. And an example of this was the COVID-19 vaccine trial, where the vaccines were used on trans people without having conducted research on them. And therefore, there is a call for developing guidelines on ethical conduct of research with LGBTQIA people so that their rights are protected, but at the same time, they are included in research. Speaking on abortion services, abortion is criminalized in India unless done under the Medical Termination of Pregnancy Act. And unfortunately, these services are only limited legally to women. However, this month, a few months back, the Supreme Court's interpretation included people of all gender and not just cisgender women to provide abortion services, and that was a landmark decision. In spite of that legal allowance, however, there's a lot of gatekeeping which is done by healthcare providers when it comes to trans men and non-binary folks seeking abortion, and that pushes them towards unsafe and harmful abortion practices. Coming to cancer screenings and the cancer prevention advice, we need to understand that a lot of trans people have the same or maybe even increased risk of certain cancers like breast cancer, cervical cancer, prostate cancer, liver cancers, ovarian cancers. And they are often not provided screening or the advice because they are only now identified by their affirmed gender. So a trans woman, for example, may not receive advice on prostate cancer, or a trans man may not receive advice on breast cancer. Now, we do understand that there are sexual differences when it comes to cancer development, and the same should be taken into consideration when providing care for trans and non-binary folks. Also, the effect of HRT on any increased risk of cancers of various kinds needs more research. We also propose dual identification to avoid patient errors, where we say that the person should write their sex assigned at birth as well as the gender identity of the recognition so that their dignity and respect is maintained while providing medically correct treatment to the person. Also, we have often advised for organ checklist, where person, irrespective of the gender, makes a checklist of the organs that they have so that the specific services can be provided. And we also ask for inclusion of legal name as well as the chosen name and pronouns to avoid medical errors. These are certain asks that we have from the various stakeholders, including governments. We ask for revision of health laws pertaining to the sexual and reproductive health of trans people and access to various healthcare services, development of national level guidelines and revision of various health policies. We ask for development of national guidelines, especially for provision of gender-affirming care and for intersex conditions. We ask for more regulatory mechanisms for quality control and grievance redressal, specifically in the domain of gender-affirming care and especially in the domain of surgical care. We also ask for revision of healthcare system infrastructure policies and SOPs so that all genders are included in the administrative and data entry component of the healthcare provision systems. Lastly, I want to say that we cannot really talk about patient safety for the queer folks unless they are also included in the process of deliberation, in the process of development and revision of these guidelines, in line with the principle of nothing about us without us. Thank you so much for giving me this time and for patient listening. In case of any comments or feedback, you feel free to write to me on this email address. Thank you and have a nice day.
Thank you, Dr. Aqsa. Really inspired us, makes us think. And I said what applies to Aqsa's case applies to us as well. Those are the same things we are asking. That when somebody says, what is a diet for a diabetic or a diet for a heart disease patient? It's the same thing we should be eating. Good diet is for all. So good policies, healthcare policies are common to us. It's recognizing the human and the compassion in it. Now, last speaker here for this session is going to be Ek, talks at a personal level, but also from the Hemophilia, high-risk association, when things were really going bad with blood donations and blood product. Ek, all the way to you.
Good morning, everyone. It's my pleasure to be here, and thank you for having me for the session about the patient safety. Hemophilia is the long life disease. So I have this disease since I was born, so I can call myself as a patient expert in this area. And like Kawaldip said, we would like to have at least one patient in every government policy meeting. But on the way to get the patient to that level, sometimes it's not easy. Today, I'm going to share my experience as a patient safety in Thailand. And this is a program that healthcare accreditation in Thailand brought it to Thailand from WHO. So HAI in Thailand bring all the chronic diseases patient group, which is very smart thing to start with the patient organization who had the experience with the hospital and healthcare provider to get together and sharing experiences. And this is the first time that I feel like my engagement to the healthcare provider start, and the government representative listened to this group of patients to bring this patient input to the healthcare system. So that you can see that they have all along more than 10 years of this program in Thailand. This started in 1997 that we start to join with the WHO patient safety, and they bring this to Thailand. At the beginning, they're sharing this program with a certain patient group. They not announced to all the patient organization in Thailand. For the background that the patient in Thailand, and I believe in Southeast Asia, the patient is really passive in this region and also humble. When you say humble, they difficult to share what they want or they really want to have for their help or support. They're waiting for the doctor to tell what the best to do or some beneficial from the government. And also if you start thinking deeply about the culture, In Asian culture, we just follow what the adult or whoever have a reputation to say what to do. And also in the education, we still, in the term of the development of the education, to have the student to share their experience, to switch from the teacher center to the student center. So now our student can speak more and more and share their experiences. So that is the culture that bring to the patient, that it's the time to the patient to speak up and share their experience, and they can be a part of the stakeholders. The big move is start in 2018, that the Patient Safety in the Hospital project and World Patient Safety Day. That the day that the year that we start to have the patient safety in Thailand. So this is the first group of the patient we can get together as a chronic diseases. We call Healthy Forum. Start with 8 diseases. We have HIV, kidney, heart disease, disability group, cancers, diabetic, medical victim, and hemophilia. So this group of chronic diseases representatives get together, sharing their experience. And it comes with something very simple things that we would like to have for a common thing for a patient safety. And this is the reason why the HA in Thailand picked up the chronic disease group to be the starter group for the patients. So this group have the long journey with doctor and caregivers and the hospital facilities. Other diseases, they might visit the hospital once a while, but this group of patients, they might visit the hospital every week, every month. They know how the public hospital, private hospital treat the patients. So this kind of good information to start with. And exists patient organization because this group, there is a chronic disease. So they start to get together and they have some kind of fundamental information that can share. We call the patient champions. So we try to find one patient champion in each group and bring them to as a representative to join, and not only in the local level. We bring them to the international level to share our patient champion experience in Thailand with other patients in Southeast Asia or in the global perspective. So this is a picture that we have the conference in Thailand. We have the group of the patient to represent the patient safety perspective in Thailand. I think this is the first document that come up from the patient experiences. So it's kind of a two-way communications. First, we have to treat, we got to train our patient what we're supposed to tell the doctors, our personal condition that we should tell. So this is a patient group that to have the involved in this program. We call the patient experience for safety awareness tools. We have the checklist about what we're supposed to tell the doctor. And at the end, we ask the doctor, are you tired with treat the patient at the clinic? So this is the thing that we try to build up the relationships with the healthcare provider also. Okay, so I will translate in English. So first one is do not forget to tell the doctor about the congenital disease that you have, and any other medication that you're taking right now, any allergies, other concern or worry in terms of mental, and also the contact person is in case you have emergencies. And the last one is ask the doctor about, are you tired? Okay. And I would like to say at the end that the patient organization could be the play in the important role in all stakeholders. But how the patient organization build up the strong organization, they need all support from other stakeholders too. Doctors play the most important role. In my case, hemophilia is one of the common rare disease. It's difficult for me to figure out where the patient I can bring together. Without the doctors, it's so difficult and time consuming. Also the industry also can be one of the important stakeholders to support the patient organizations. But at the end, the patient have to build up this strong organization by themselves. They have to figure out how to join with other policymakers and not influenced by others stakeholders. That's the key important thing. Thank you very much.
Thank you, Ek. Excellent overview of time. So I've just got some questions to ask now. Firstly, to Ek, somebody has just sent, are you thinking of forming a national Thai patient safety alliance?
Yes.
And the next
I
question
believe...
they've put is, when can we meet after this event?
Yes, and I think that one of the things that in Thailand we have a couple organizations, we try to do that. It's going to be benefit for all, not only the chronic diseases, and we try to develop the benefits of the patient organization with the rare diseases also. So this group of patients, very low number of patients and low number of the doctor who knows about the rare disease. But we encourage them at least to have the patient organization run through. And if we have this kind of alliance, they can support them more and more.
Thank you. Thank you. So I think Orajit. So Orajit has her work cut out for this. Orajit, you have a nice opportunity to set up a national Thai Patients Alliance here today at 4 o'clock. So you have a great opportunity. Orajit is there, so please go to her, submit your names, and you join up. The next question is for Nidhi, I think. Nidhi, this is from Maldives for all very within the region. So what this person is saying that, can you share your experiences with them? They would like to do something with you because you, for some reason, Singapore and Maldives are same island states, Maldives. Would you be able to share your experience with others as things come up? Will you be forming some kind of organization for small island states or something similar?
Yeah, I'm more than happy to have conversations with others. My last slide couldn't come up on, but I could request the Secretariat to share my contacts with whoever needs to have a chat. I can do what little I can, yeah.
Okay. And then this is something that I think is coming from, I can't see the country, but the question is, do you have a national patient safety action plan? And can they get access to this? Now, Ek, for you.
Yes, I believe they do. But I think in the healthcare accreditation, they have this information, and it could link with the WHO patient safety also. And we try to build up the national. And in my experience, I forgot to tell about when we have the patient organization, we try to develop the patient's organization to be a national one. And when they come to the national level, there should be only one national level. Otherwise, they have some conflict of interest of the patient organization too.
I'm so glad you talked it, because I think one of the things we were discussing with the Thai minister in WHO Sierra meeting was this, even with Ketrapal from Malaysia, the regional director, that we need one unified voice sitting at the table. And so it's imperative for us to set up that national Patient Safety Alliance and bring it on. And the most important part of this is we need leaders who can carry forward the rest of the patient movement. I think at this moment we don't want to have fractious leaders or leaders who have the tendency to rub people in the wrong way. We have ways of insulting patient organizations who have a way of being brusque, a way of being very much narcissistic and me. We need us. I think that's what is very essential for us. We need leaders who can bridge that gap. You know, we need Nelson Mandelas of the leadership. And that's what we need in National Alliance, how to bury our axes and share those. I think that's something very important that was coming through, because the politicians or most of the health ministries were saying that who do we come and talk to? In Monday morning we talk to someone A and we agree something, and at 4 o'clock that's changed because organization B wants something else. Can you speak with one voice? So I think this is something that we need to take away from for this region. Let's talk with one voice, and let that voice be consistent, and let that voice be evidence-based. It's time to do now, roll up our sleeves and forget the me and bring us the us into it. And now I'll open the questions before we take a break. Any questions? Radna? Mike?
Thank you, Kawaldip. I have a comment and then a question. The comment is that we have the Asia Pacific Patient Safety Network with an advisory board of 8 members from 8 different countries. Orajit represents Thailand in that. And we recently conducted a survey trying to understand what patient safety means to patient groups. And we presented this at an international conference, and it threw up some really startling results. So one of the questions was how many patients were confused with similar looking packages but different medications. And a whopping 90% said we were, especially when the strip is removed from the box and you get a part of the strip cut, which happens in most of the countries in this part of the region. So something as similar as, as small as that could lead to wrong medication and harmful effects to the patient. And because we did the survey, that created a baseline of what patient safety means to patient groups. And WHO CRO and WHO Wipro, as well as some of the countries of this reason, have agreed that this needs to be escalated and more information collected so that it can be published as a paper. So I welcome anyone who wants to run this survey within these patient groups and collect that information. This was the comment. The question is to you, Nidhi. You have the Institute of Patient Safety and Quality in Singapore, which is doing fantastic work. Similar institutions exist in all the countries of this region. Do you see a benefit for these national organizations that represent patients to work hand in hand with these quality institutions so that the patient safety is not 2 different voices, but a common voice that comes from each country?
Yeah. Thanks, Ratna. I think you have raised very valid points, and it's an interesting question. I've just started on this journey, and definitely we can work together because, like you said, the definition could be different. And what patients are looking for is naturally their own safety and for the, maybe for the caregivers that are taking care of patients. So when we put our heads together, I think we will have better outcomes. And that is what I'm talking about, that all stakeholders need to come together. I'm just talking about within Singapore, but if we can get guidance from overseas, most welcome. Yeah, thank you.
Thank you, Nidhi. Please do join the network.
Rick, anything to say?
Yes, sometimes when people get together, patients get together and share their experience, the outcome maybe sometimes is very common. And communication with the doctors, the languages, not the diversity of the language, but the medical language sometimes is make the patient don't understand about what the doctor said. And also that can cause some of the patient feel not safe with the informations. So sometimes we have to translate from the doctor language to the simple language that the patient can understand. So this is something that the patient can work together, and maybe healthcare provider, they never realize about that.
Can I just add to that? Under the Sing Health Patient Advocacy Network, we have developed a plain language glossary. It is for medical practitioners, so we can share with you and anyone else.
I think that's very good. I think this is something that the Maldives person was saying about shared resources. Can I just add to that comment from Ratna's as well? Medication safety is a very precise part of that Global Patient Safety Action Plan, and there is a parallel stream to it with the third medication safety challenge that WHO is running. And one of the things that IAPO is part of is the Fight the Fakes Alliance. Fight the Fake Alliance and others in European Union as well. We are pushing for e-labeling now as mandatory, QR codes on all products, and to ensure that we are using digital technologies to establish the authenticity of medicines quickly, and also for patient education and community literacy, and plus ensure that we fight the fake. Do follow that medication safety from WHO, and do join Fight the Fakes Alliance as well. All that is available to us on various parts. And with that, I think, without cutting into the thing, one more question from Anson.
Hi, good morning. Just a quick one. I love the vision of having one voice and having one organization representative to consolidate all the concerns of the patients. But what I'm hearing is that you are creating a coalition for a specific department, like the patient safety. Perhaps another venture of it is a group of health technology assessment. I'd just like to understand what is the value of having a different coalition between the consolidated organization that represents the whole of patients.
So they have a different, they have a level of the patient, each patient's organization to develop their own organization and develop what they need. And also we bring all the patients together. And in Thailand, we have the universal health coverage department that they have also worked well with the HA, the healthcare accreditations. And these two departments is two the main important roles to bring the patient together to get the information to develop the policy. And also when they would like to have the representative from the patient to join for the policy maker, they will looking for this group and find out the representative to that level. And also not only we try to get to that level, we try to bring all the fundamentals, safety care, patient safety to others, patient organization too.
Thank you very much. Now, before we go into break, I think, as you answered, to answer to yours was that we're trying to define the patient harm elephant. So the more people you bring into a national coalition, the better. Rare diseases, don't forget minor groups. Again, as I said, Dr. Aqsa, Shaikh had said, let's all sit together and define this elephant. And the elephant needs to be defined at a national level, you know. If someone collapses on your street, they don't ring WHO, they ring the health ministry, so you want to know what's happened. So we'll go into a break now. Those who are interested in the value-based healthcare and HDAP, please stay here. And those who will be in the rare diseases are in an adjoining room. We will be shutting that partition there. So the second room. You have a coffee break now. Please go and have your coffee. And you can saunter in. We have said 11:30, but take your time. You can bring your coffee in there. And we try to start on time at 11:30, if possible. So thank you very much, everybody, for this session. And I'm glad you bore the Bangkok traffic very well. And thank you.